Now, if you look at the prevalence of just a headache complaint in these patients, it's about 84%. This is a study from Deb Friedman. Now, there's this new criteria. This is proposed also by Deb Friedman, was published in Neurology in 2013, of this diagnosis called IIH without papilledema, the diagnosis of migraine in primary care, and truly represents one of the most important modules of the entire program. First, to learn the prevalence of migraine. Second, to recognize the underdiagnosis of migraine. Third, to apply the current migraine diagnostic criteria to learn abbreviated diagnostic tools that will simplify the diagnosis of migraine in your practice. And finally, fifth, to be able to follow a general approach to the diagnosis of migraine and other headache disorders. One study found that a diagnosis of migraine and tension-type headache occurred in 49% of cases, while migraine was the sole diagnosis in 51% of cases. If you ask the question, describe your headaches, plural, to someone with multiple headache types, then you may get some symptoms characteristic of migraine.
In those patients, cognitive behavioral therapies can be beneficial. Trigger factor management is an important component of migraine management. Migraine is a genetic disease of the nervous system that leads to hyperresponsive nerve cells within the central nervous system. Examples of trigger factors include stress, lights, noise, odors, diet, dehydration, hormonal changes in women, weather changes, and poor posture. The more triggers that are present, the more likely a migraine will occur. You have to have an understanding of the anatomy of a migraine attack. As shown in the diagram, the trigeminal nerve innervates the dura itself, as well as the dural blood vessels. It synapses on a second-order neuron in the brainstem, which synapses on a third-order neuron, which goes to the sensory cortex, where pain is perceived. During a migraine attack, the peripheral trigeminal nerve first becomes activated, followed by the second and third-order neurons. If the second-order neuron is repeatedly stimulated, like when a refractory migraine attack occurs, then it becomes sensitized. This is called central sensitization. Once central sensitization has occurred, second-order neurons are more likely to activate with less provocation. We believe this occurs more readily with chronic migraine and may lead to more frequent headaches. One sign of this central sensitization is a physical finding called allodynia. Allodynia means that a sensory stimulus that is normally perceived as non-painful is perceived as uncomfortable or even painful. Examples of allodynia include light touch to the forehead or the side of the head being perceived as painful, or a perception that one's hair hurts during a migraine attack. As such, routine activities that cause tension on the hair may hurt, such as combing the hair or wearing a ponytail. In one study, it was found that over 90% of people with chronic migraine can have some degree of allodynia.